Okay, let's unpack this. Picture yourself, you're a nursing student, wading through all this information, and then bam, you hit neurocognitive disorders. It can feel, well, a bit overwhelming, almost like your own brain's fogging up, right?
Well, absolutely. It's a
Yeah,
common feeling. There's just so much complexity there.
exactly. And that's what we're aiming to do today, sort of cut through that noise.
Right. We're focusing this deep dive specifically on neurocognitive disorders, NCDs for short.
And we're grounding this conversation in a really solid source, Chapter 22, Neurocognitive Disorders, from the Davis Advantage for Psychiatric Mental Health Nursing, 10th edition.
Yeah, it's a detailed, expert level resource. So we're pulling out the essentials from that.
Our mission really is to zero in on what's crucial for you as a nursing student to understand about NCDs. We're talking pathophysiology, what's happening in the brain.
The signs and symptoms you'll actually see.
Yes, and then the nursing care itself. What interventions are vital and what treatments are available.
So think of it like a roadmap. We'll start with the basics, the core concepts of NCDs. Then we'll look at the main types you'll encounter.
Like delirium, that sudden confusion.
Exactly. And major NCD, which people often call dementia, and also mild NCD, that earlier stage.
Oh, okay. And you mentioned something important earlier, telling the difference between NCD and something called pseudodementia. We'll cover that.
Definitely. It's crucial. We'll also touch on the things that might make someone more likely to develop an NCD, the predisposing factors.
And how we assess for them.
Yes, assessment methods, absolutely. Then we'll shift into the nursing process, key diagnoses, the outcomes we're aiming for.
And the interventions, the hands-on stuff.
Right, the practical nursing actions, plus the medical treatments, including specific medications you need to know.
And finally, patient and family education. Super important.
Couldn't agree more. It's a lot, but we'll break it down piece by piece.
Perfect. So let's start right at the foundation. What exactly is a neurocognitive disorder?
Okay, so fundamentally, an NCD means there's been a significant decline in someone's cognitive abilities compared to where they were before.
And cognitive abilities covers a lot, doesn't it?
It does. The textbook highlights 6 main areas. There's attention, focus, executive function, things like planning, organizing, problem solving.
Memory, obviously.
Memory, of course. Language understanding and expressing. Perceptual motor skills, like hand-eye coordination. And social cognition, picking up on social cues, interacting appropriately.
So a noticeable drop in one or more of those areas, enough to impact daily life.
That's the essence of it, yes, affecting their functioning.
Got it. Now, you mentioned delirium first. It seems quite distinct because it comes on so fast.
It really is distinct. Delirium is an acute cognitive disturbance. Acute meaning sudden onset. And here's the key part. It's often reversible.
Reversible. Okay, that's a big point.
Huge. If you can find and treat the underlying cause, the confusion, the disorientation, it can clear up. It's like a temporary brain malfunction.
So what are the signs we'd see? You mentioned confusion.
Yeah, disorientation is a big one. Not knowing where they are, the time, the date, hallucinations, seeing or hearing things. Agitation is common, but sometimes they can be really withdrawn, hypoactive. Their speech might be rambling, incoherent. Sleep patterns are usually totally disrupted, and their level of consciousness can fluctuate wildly, alert 1 minute, drowsy the next.
Wow, that sounds really jarring for everyone involved.
Yeah.
What kinds of things trigger delirium? What are those underlying causes we need to find?
Well, there's a whole range. Infections are a really common one, especially UTIs in older adults. You might see confusion as the main symptom.
Right, I've heard that.
Substance withdrawal is another big trigger. Metabolic imbalances, think dehydration, electrolyte problems like low sodium, blood sugar issues.
Okay.
Also problems within the brain itself, like a stroke or seizure. And medication toxicity, polypharmacy in older adults is a frequent culprit, especially drugs with anticholinergic effects.
Makes sense. So many potential causes. Okay, so delirium, sudden, fluctuating, often reversible if you treat the cause. Now, let's contrast that with major NCD or dementia. How's that different?
It's a fundamentally different process. Major NCD, or dementia, involves a progressive decline in cognitive function. And crucially, it's generally considered irreversible.
Progressive and irreversible.
And unlike delirium, the person's level of consciousness isn't typically impaired, certainly not in the earlier stages. The decline happens gradually, chipping away at those cognitive domains we talked about.
Attention, memory, executive function.
Yeah, all of those. And it eventually gets to a point where it significantly impacts their independence, their ability to manage daily life.
And dementia isn't just one single disease, right?
Yeah.
The book mentions several causes.
Correct. It's an umbrella term. Alzheimer's disease is the most common cause by far. That involves those amyloid plaques and neurofibrillary tangles disrupting brain cells.
Okay.
Then there's vascular dementia, caused by reduced blood flow to the brain, often from strokes, big or small. Lewy body disease is another one. You get these abnormal protein deposits, Lewy bodies, and often see fluctuating cognition, visual hallucinations, and Parkinson's-like motor symptoms.
It sounds complex to manage.
It can be. There's also frontotemporal degeneration, affecting the frontal and temporal lobes, leading more to personality, behavior, or language changes early on.
Interesting how the location affects the initial symptoms.
Exactly. And less commonly, you have causes like HIV infection impacting the brain, traumatic brain injury, Parkinson's disease itself in later stages, and very rare conditions like prion disease.
So lots of potential underlying pathologies leading to that progressive decline. Now, what about mild NCD? Where does that fit in?
Mild NCD is sort of that intermediate stage. People experience a noticeable cognitive decline from their baseline, but, and this is the key difference from major NCD, they can still function independently in their daily lives.
Okay, so they notice it, others might notice it, but they can still manage.
Yes, though it might take more effort, or they might need to use compensatory strategies like writing everything down. Recognizing mild NCD is so important for early intervention.
Why is that?
Because it allows us to start monitoring more closely, provide support, maybe implement strategies to help manage the changes, and track if it's progressing towards major NCD. Early awareness makes a difference.
That makes perfect sense.
Yeah.
Now, something else that seems critical for nurses is distinguishing NCDs from pseudodementia. Can we unpack that?
Absolutely essential. Pseudodementia basically refers to cognitive symptoms that look like dementia but are actually caused primarily by depression.
So depression mimicking dementia.
Exactly. And the critical point is, if you successfully treat the depression, the cognitive symptoms often improve significantly. Unlike the irreversible decline in most NCDs, the textbook actually has a great comparison table.
Okay, let's walk through some key differences. What about the onset? How quickly do symptoms appear?
With most NCDs, especially Alzheimer's, the onset is typically slow, insidious, creeping up over months or years. With pseudodementia linked to depression, the cognitive changes often appear more rapidly, maybe over weeks or a few months, often tracking with the start of the depressive episode.
That's a big clue. And memory problems. How do they differ?
In NCD, the person might try to cover up memory gaps, sometimes confabulating, making things up without realizing it. They often seem unaware of how bad their memory really is.
Okay.
Someone with pseudodementia is usually very aware of their memory issues. They're more likely to complain about it, and instead of guessing, they'll often just say, "I don't know," when asked something.
Interesting. What about orientation knowing time and place?
As NCD progresses, disorientation to time and place becomes more common. With pseudodementia, the person usually stays oriented. They know where they are, the date, etc.
And how they handle tasks?
In NCD, performance on tasks tends to be consistently poor because of the underlying cognitive deficit. With pseudodementia, performance can be more variable. They might do okay sometimes, poorly others, and often show little effort or motivation.
That lack of effort sounds very much like depression.
It does, and related to that is the affective response, their emotional state. In NCD, you might see apathy, a kind of blunted emotional expression.
Whereas with pseudodementia,
They're more likely to communicate distress, sadness, anxiety, hopelessness. The emotional pain is often quite evident.
okay, and attention concentration.
Generally more significantly impaired in NCD due to the brain changes. In pseudodementia, while focus can be hard because of the low mood, the basic capacity for attention is often more intact underneath.
Are there physical clues too, like appetite?
Yes, that can differ too. Appetite is often unchanged in NCD, at least initially. But in depression leading to pseudodementia, appetite is frequently diminished. Significant weight loss can occur.
Right. And finally, what about sundowning? That worsening of symptoms in the evening.
Sundowning, increased confusion, agitation, restlessness in the late afternoon or evening is pretty characteristic of NCDs, especially Alzheimer's.
And not typically seen in pseudodementia.
Not typically. In fact, with depression-related pseudodementia, the person might actually feel a bit better or clearer as the day goes on. So these distinctions are really vital for getting the diagnosis and care plan right.
Absolutely critical. Okay, moving on. What makes someone more vulnerable to developing an NCD? What are those predisposing factors?
The book groups them nicely. There are biological factors like hypoxia, lack of oxygen to the brain, maybe from severe lung or heart disease, vitamin deficiencies, especially B12 and sometimes C,
Okay.
endocrine issues like thyroid problems, electrolyte imbalances, then infections affecting the central nervous system, encephalitis, meningitis, HIV.
Right, HIV-associated NCD.
Exactly. Then there are toxins and medications, chronic alcohol abuse, certain medications like anticholinergics, some antipsychotics, sedatives.
Things nurses administer, so important to know.
Very important. And finally, structural factors, brain tumors, damage from strokes, traumatic brain injuries, and other neurodegenerative diseases like Parkinson's all increase risk.
That's a wide net. It really emphasizes protecting brain health overall. So, if we suspect an NCD, how does the assessment process work?
It's a multi-pronged approach. You start with clinical assessment, including mental status exams, things like the mini mental state exam, the MMSE, or maybe the MoCA Montreal Cognitive Assessment.
Those screen different cognitive areas.
Yeah, they give you a baseline score on orientation, memory, attention, language, etc. Then lab tests are crucial to rule out reversible causes, things that might look like NCD but aren't.
Like the vitamin deficiencies or thyroid issues you mentioned.
Precisely. So checking B12, thyroid hormones, glucose, electrolytes. A toxicology screen if substance use is a possibility.
Makes sense. What about looking at the brain itself?
Brain imaging comes in here. CT scans or MRIs can show structural changes like atrophy, evidence of strokes, tumors. Sometimes specialized scans like PET scans, including amyloid PET scans for Alzheimer's, might be used, though they're less common in routine diagnosis.
Okay. And what about just talking to the patient and family?
Absolutely fundamental. A detailed history is key. When did symptoms start? How quickly have they progressed? What are the symptoms? Any other medical conditions? Full medication list prescriptions? Over-the-counter, supplements, how is it affecting their daily function?
And getting the family's perspective seems vital.
Incredibly valuable. Often the person with the NCD may lack insight into their deficits, so family members or caregivers provide crucial information about the changes they've observed. It's about piecing together the whole puzzle.
Right. So once that assessment leads to an NCD diagnosis, what are the common nursing diagnoses we'll be working with?
Given the symptoms, you'll often see diagnoses like risk for trauma because of impaired judgment and safety awareness, disturbed thought processes, impaired memory,
Makes sense.
disturbed sensory perception, especially if there are hallucinations, maybe with Lewy body disease or delirium, risk for other directed violence if agitation or aggression is present.
Communication can be tough too, right?
Definitely. Impaired verbal communication is common. And as function declines, self-care deficit needing help with ADLs. And don't forget the emotional impact. Situational low self-esteem can be significant.
That's a good range reflecting the holistic impact. So what are we aiming for? What are the desired patient outcomes?
The goals have to be realistic and patient-centered. Primarily, we want the patient to remain free from injury, no self-harm, maintain reality orientation to the best of their ability, understanding that might decline over time.
Right.
We want them to participate in activities of daily living, ADLs, as much as possible, even with assistance, to be able to communicate their basic needs, hunger, thirst, pain, and hopefully to discuss positive aspects of their life, maintaining some sense of self-worth.
Focusing on safety and quality of life. Now let's get practical. Nursing interventions, especially for safety. What do we do?
Safety is huge. First, create a safe, structured environment. Remove hazards. Think, throw rugs, clutter, poor lighting. Consistent routines are really important. Predictable schedules reduce anxiety.
Consistency seems key.
It really is. Using consistent caregivers whenever possible helps too. Reduce excessive environmental stimuli, loud TV, too many people talking at once that can be overwhelming and trigger agitation.
Good point. What about mobility?
Assist with walking, ensure they use walkers or canes correctly if needed. Bed alarms or chair alarms might be necessary. Lock away potentially dangerous items, medications, cleaning supplies, sharp objects. And ongoing monitoring for wandering or signs of escalating agitation is crucial.
Constant vigilance. And how do we support them with those activities of daily living, the ADLs?
The goal is to foster independence for as long as possible. Encourage them to do what they can, but be ready to assist. Allow plenty of time rushing increases frustration.
Patience is key.
Absolutely. Break down tasks into simple, manageable steps. Instead of get dressed, maybe say, put on your shirt. Maintain familiar routines around bathing, dressing, meals. Using visual cues can sometimes help.
Like laying out clothes in order.
Exactly. And again, minimizing changes in caregivers helps maintain that routine and reduces confusion during personal care tasks. Offer choices when possible to maintain dignity, like, would you like the blue shirt or the red one?
Small things that maintain personhood. Okay, let's talk treatment. What medical or pharmacologic options are there?
Okay, for delirium, remember the main goal. Treat the underlying cause. If that UTI is treated or the electrolyte imbalance corrected, the delirium often resolves.
But what if the person is severely agitated?
In that case, short-term use of antipsychotics might be considered to manage severe agitation or psychosis that poses a safety risk, but it's usually low dose, short duration, and carefully monitored.
Got it. Now for NCDs like Alzheimer's.
Here, the medications primarily aim to manage symptoms. The main class is cholinesterase inhibitors. These include donepezil brand name Aricept rivastigmine, which comes as Exelon, and galantamine, or Razidine.
And how do they work?
They work by increasing the level of acetylcholine in the brain, which is a neurotransmitter important for memory and thinking. They don't stop the disease, but they can help manage cognitive symptoms for a time, maybe slow the decline slightly for some people.
So symptom management, not a cure.
Exactly. It's crucial to understand that. Then there's another medication called memantine, brand name Namenda. It works differently on the glutamate system.
Okay.
Memantine is often used for moderate to severe Alzheimer's, sometimes in combination with a cholinesterase inhibitor. Again, the goal is managing symptoms like confusion, maybe improving function slightly, not a cure.
So donepezil, rivastigmine, galantamine, and memantine. Good to know those names and their purpose.
Yes, you'll definitely encounter them in practice.
Beyond meds, education for patients and families seems massive. What are the key teaching points from the book?
Absolutely critical. Box 22-5 highlights this well. First, education about the illness itself. What is Alzheimer's or vascular dementia? What causes it? What symptoms can they expect? What's the likely progression? Setting realistic expectations is vital.
Managing uncertainty.
Right. Second, practical management strategies. How to ensure safety at home. Techniques for reality orientation using calendars, clocks, familiar photos. Tips for nutrition, hygiene, managing challenging behaviors.
Empowering the caregivers.
Totally. And third, connecting them to support services. This is huge. Caregiving is exhausting. They need to know about respite care options, getting a break, adult day programs for the person with NCD. Support groups are invaluable talking to others going through it.
And specific organizations.
Yes, mentioning resources like the Alzheimer's Association, the Parkinson's Foundation, local area agencies on aging. These organizations offer incredible information, support, and resources. We need to make sure families know they exist and how to connect.
That comprehensive support makes such a difference. So after we've implemented our care plan, how do we evaluate if it's working?
Evaluation is ongoing. We constantly reassess those short-term outcomes. Is the patient safe? Are falls being prevented? Is their reality orientation maintained as best as possible? Are they participating in ADLs with the right support?
Checking back on the goals.
Exactly. We also need to evaluate the effectiveness of our caregiver support and education. Do the caregivers feel more confident? Do they understand the disease process better? Are they utilizing coping strategies and support services?
It's evaluating the whole system, patient and family.
It has to be. Ultimately, the evaluation looks at whether we're achieving the overarching goals. Maintaining the person's dignity, maximizing their quality of life, and supporting their functional abilities within the context of the disease progression.
Okay, so wrapping this up, what are the absolute key takeaways for nursing students listening to this? The must-remember points about NCDs.
I'd say number one, grasp the core difference between delirium acute, potentially reversible in dementia, or major NCD progressive, irreversible. That's fundamental.
Right.
Number two, understand the importance of a thorough assessment history, mental status exams, labs, sometimes imaging to identify the type of NCD and rule out other causes. 3, always prioritize safety in your interventions. Structure, routine, hazard reduction, monitoring. And closely linked is supporting ADLs, promoting independence while assisting as needed.
Safety and function.
Exactly. 4, know the main medications cholinesterase inhibitors like donepezil and rivastigmine and the NMDA antagonists memantine, and understand their role is primarily symptom management, not cure.
Manage expectations around meds.
Yes. And finally, number 5, Recognize the absolutely vital role of patient and family education and connecting them to ongoing support resources like the Alzheimer's Association. You're caring for the whole family unit.
That's a fantastic summary. It really underscores that caring for patients with NCDs requires not just clinical knowledge about the diseases, but also sharp assessment skills, practical nursing interventions focused on safety and function, and real compassion for both the patient and their loved ones.
It's definitely a challenging field, but also incredibly rewarding. Your care truly makes a difference in maintaining dignity and quality of life.
A powerful message. Well, thank you so much for walking us through all of that. It's been incredibly insightful.
My pleasure. Happy to help clarify it.
And for all of you listening, we hope this deep dive has given you a solid foundation for understanding neurocognitive disorders. Maybe take a moment to think about how this knowledge connects to your clinical experiences or your future practice. Perhaps check out those support organizations we mentioned.
And maybe reflect on this. As you move forward in your careers, how can you champion a care approach that truly sees the whole person behind the diagnosis, focusing not just on deficits, but also on remaining strength and their essential human dignity?
A really important question to carry forward. Thank you again. And thanks to all of you for joining us on this deep dive.